we have got our next speaker. I talked about the celiac or gastro power couple, and we now get the other side of that power couple, Adele Rostami, who has over 24 years of advanced training and experience in various special areas of nutrition therapy, including gastroenterology, paediatrics, diabetes, disorder eating, oncology. But recently she's been working in specialist dietitian for Digestive Health Clinic. That'll be in Palmerston North as well, yes, and dealing with the non-responsive celiac disease. So, and having what we just heard about the different degrees of celiacs that we have, really keen to hear from you. Thank you very much, Adele. We still may have a prize. Adele is concerned there is a spelling mistake. Obviously a very international person, so it goes across a lot of languages. So maybe a prize for any spelling mistakes.
Thank you, Sam, for that introduction. Kia ora koutou, and thank you for keeping us entertained throughout the conference. Thank you, Celiac New Zealand, for giving me this opportunity to come and talk to you all about the dietary management of non-responsive celiac patients. Let's see if I can work this thing. So today we are going to talk about what is non-responsive celiac disease. I'm going to talk a little bit about the deep dive dietary analysis that we should be doing as dietitians, what factors contribute to poor dietary adherence. I think Karen and John have spoken quite nicely about that as well. We're going to touch on the gluten contamination elimination diet and what other potential causes there could be. We're going to look at some case studies and just touch on refractory celiac disease type 1 and type 2. So as you've already heard today, non-responsive celiac disease is defined as persistent symptoms, signs and lab abnormalities and deficiencies despite a 6 to 12 months adherence of a strict gluten-free diet. It can affect 1 in 3 celiac patients, and the most common cause for this is intentional or inadvertent gluten exposure. So as Jason and Bob have quite rightly said, it is imperative for these patients to have a gastroenterology review because a correct diagnosis of celiac disease does need to be confirmed. We know from the literature that there could be around 10 other causes that needs to be excluded before we can make a correct diagnosis of refractory celiac disease. And once the team has confirmed that this diagnosis is correct, this is where us as dietitians come in, and we will then do an in-depth dietary analysis of these patients. So, of course, we will do the usual nutrition assessment. We will look at the medical, family, diet history, and the biochemistry. There's my spelling mistake. And of course, with the utmost sensitivity and compassion and understanding, we will have a deep dive into the following things. So we have to really do a detailed investigation of the living situation of our patients. Are they sharing kitchens, utensils, toasters and condiments? Who participates in the food shopping and the food preparation? How supportive are the family members? Are they in denial of the diagnosis? Are they trained on label reading? Do they understand English? We see more and more refugee families coming to New Zealand, and that needs to be considered. Do they know hidden sources of gluten? I mean, are people that come from other countries familiar with the fact that oats in New Zealand is quite heavily contaminated, which may not be the case in other countries? We have to look at the food environment and availability and affordability of our safe gluten-free foods. As we've heard today, and many other studies have shown, is that gluten-free products can be 22 to 400% more expensive than their gluten-containing counterparts. And for many families, this can be a real obstacle to overcome. We also have to look at the food culture and traditions and beliefs of families. And we had this conversation last night about how many cultures use food as a way of showing love, and how it can be perceived if they offer you food and you're not accepting it as a kind of insult to some people. So we have to consider, what are the cultural norms of the family? How has this changed their food traditions? And what's the family and friends' reactions to the restrictions that these patients are now having to follow? We have to look at the level of knowledge. Are they able to identify safe gluten-free products and ingredients? And do they understand the consequences of cheating? They may say, oh, a little doesn't matter. Yeah. So again, we have to look very closely at the support systems that our patients have. Our close family members and friends, are they supportive of the diagnosis or in denial? And it may mean that we need to include family members in our consultations, or they may even need to be referred on further for family counselling. It is really important for our patients to feel connected to either family or their friends or other support groups. And I think Karen has talked quite nicely about the mental health impacts, really. The psychosocial considerations, we know that if we can identify the barriers and work with our patients on those barriers, that it will aid compliance. So it is quite an emotional journey for many of our patients. And a lot of the presentations today kind of, touched on that. And there's a lot of feelings of loss and anger, loss of control, anxiety. Some patients are scared of developing cancer. Others are afraid that they may pass it on to their children. And there's sometimes also a sense of relief that they finally know what they're dealing with. So it is important to see where in that journey they are, and if they've got feelings of guilt or shame and being a burden. We often see in children and young people that they can feel quite isolated and sometimes experience bullying. So, and a lot of our young people, they can feel quite frustrated with the strict nature of the diet. And there's not that spontaneity that they can just go out with their friends to McDonald's. So that can also interfere with compliance. We often see avoidance behaviors, and we sometimes see that, especially in our teenagers, the fact that they avoid to go out or eat with their peers, or maybe even traveling. So one hypervigilance study that was done by Wolf et al. Found that higher knowledge of a gluten-free diet and celiac disease was associated with higher vigilance, but that severely impacted the quality of life of our patients, and they experienced feelings of limitations. So they were constantly checking labels, menus, and so on. Teenagers especially reported more barriers, and especially around eating out and gluten-free products. 56% of adults and 70% of teens reported a negative impact of a gluten-free diet. So we often see greater maladaptive behaviors in our older teenagers, so they could become quite rigid and avoiding to eat and controlling behaviors. So it's a constant delicate balance of the healthcare professional to educate, but without causing hypervigilance, which may lead to the negative quality of life outcomes and disordered eating that we see nowadays. I also think social media has a lot to answer for. Again, eating out and traveling, like Karen has said, a lot of studies have shown that contamination happens in restaurants, quite large amounts of even gluten-free meals in restaurants are actually contaminated with gluten. So it's asking those questions. Is your patient asking those preparation questions? How and where are the food prepared? Are the staff trained? Are the toppings shared in, for instance, pizza places? Or do they have their own toppings? Do they change gloves and utensils? Talking about the risk of airborne flour in bakeries, I had one patient that wasn't getting better on a gluten-free diet, but she was baking 3 times a week for her school, and the airborne flour was really contributing to the contamination that she was inhaling. So also check their understanding of ethnic cuisine ingredients. Checking things like medication and other hidden traces, so asking what medication and supplements they are using, checking the fillers used in these brands, and check whether the brands have changed the recipes. Things that we're using nowadays more of are paper straws, because we're trying to save the environment. But again, the starch-based glue component in those paper straws can also cause contamination. Play-Doh in nurseries, and again, looking at things like cosmetics and lipstick and what fillers are used in them, and also making sure that your gluten-free patient's not sharing any of those products with gluten-eating people. So now, once you've done that deep dive analysis, in other countries in Europe, we've got the gluten immunogenic peptide test. Unfortunately, it's not yet available in New Zealand, but we can check the urine or stools of our patients. And it is found often that even if we couldn't detect any gluten through the dietary assessment, still 30 to 40% of patients still had gluten detected, even after the deep dive dietary assessment. So in New Zealand, we can't do that yet, but hopefully we will. So if that has failed, we can now consider trialing our patient on a gluten contamination elimination diet. And the reason for doing that is twofold. We know that even gluten-free products, there's quite a few studies out there that have tested them, but some of them are still contaminated with gluten. We know that cross-contamination can happen of these labeled gluten-free foods, and that can be because of crop rotations or the way that food is manufactured in factories, or the way that it is stored in the supermarket. So there's lots of points where contamination can happen. And the second part is, like Jason and Bob have quite rightly said, is some patients are really intolerant to minute amounts of gluten. So what is the gluten contamination elimination diet? It is one that should only be done by a trained dietitian, and it is not one that you will do after a patient's been diagnosed. They would need to be on, will have had to be on a normal gluten-free diet for about a year before you would try this with them. It's for the short term only because it is very restrictive, and no more than 3 to 4 months in total. We know that exclusions is not good. Too much exclusion is not good for gut microflora. There's 3 phases to this diet. We take out all processed foods, so including labeled gluten-free foods. So it's only naturally gluten-free foods in their natural state. So whole foods like Sylvia spoken of and Karen earlier. So once their symptoms subside, we will slowly reintroduce foods under the supervision of a trained dietitian. So phase 1 is the strictest, and it's the first 2 weeks. And we use in our non-responsive celiac clinic in Palmerston North elemental 0828 extra for our patients. And what we are trying to achieve with this phase is really to just help settle some of the inflammation that these patients are experiencing, and seeing whether we can achieve a little bit of remission for them. After phase 1, we will do another 6 to 10 weeks of exclusions. And dairy we usually exclude within the first 4 weeks of this diet, just because we know that there's sometimes a kind of secondary lactose or dairy intolerance associated with gluten. And then phase 3 will be the slow reintroduction, one food at a time over 2 to 3 days. Again, we ask patients to keep food and symptom diaries, and we will start with the least likely contaminated foods first, like frozen fruits and vegetables and jarred sauces and condiments, and then that would be followed by a small amount of gluten-free grains, like half a cup of gluten-free pasta or 1 slice of gluten-free bread for 3 days, and then we would add a second serving for 3 days, and if that is tolerated, the patient can resume a normal gluten-free diet. During this elimination trial, we would consider maybe multivitamins if our patients are not achieving nutritional adequacy. You may even consider things like Fortisip or Ensure Plus if they are still losing weight, or even just continue them on the Elemental O28 Extra. If they do not improve after the 8 weeks or so, you may need to consider other potential causes. Now, I can speak about each one of these for another hour, and I'm not going to bore you with that. So one of the things to consider is the fiber content of the diet, and checking that your patient's intake of fiber is consistent. We know that on a gluten-free diet, fiber is often lacking, especially prebiotic fiber, or sometimes some patients could have a higher intake of fiber, salads and so on, because they feel that they are safe foods to eat. So just check that they've got a consistent intake of their fiber. You may also want to consider sugars and whether your patient's malabsorbing lactose or fructose or sugar alcohols. And then FODMAPs is another area you can look at, but it can get quite tricky if you're now trying to exclude a lot of things. That's quite difficult to do. And then also just keeping in mind other intolerances like food chemicals as well, nitrates, sulfites, salicylates, glutamate and amines, and so on. And of course, stress and anxiety, we cannot ignore that. That is a very important part to consider. And also using those strategies, those beautiful strategies that Tanya has talked about this morning, the deep breathing, the yoga, the mindfulness, and all those things that Karen talked about, is really helpful. So now I've given you all the theory behind it. We are going to look at a couple of case studies. It's the same ones that Cameron presented earlier, and just how to put that into practice. So these 2 patients were referred to our non-responsive celiac clinic, and we'll just take you through their journey. So our first lady, like Cameron said, was from Hawke's Bay, and she came to us in March of this year. She constantly had positive serology and severe abnormal histology despite being on a strict gluten-free diet for many years. She was really quite emotional in clinic. She was really tearful. She came with her mom. Quality of life was severely impacted. She had symptoms of chronic constipation, brain fog, irritability, headaches, dizziness, abdominal pain, bloating, fatigue, joint pain, muscle aches and cramps, swelling of her tongue, fluctuating vitamin B12, E and iron levels, low vitamin D stores, heart palpitations, panic attacks, and so on. So we did a deep dive dietary analysis of her diet, and we could not find any intentional or inadvertent gluten ingestion. So we put her on 2 weeks Elemental O28 Extra, which she tolerated well, except for the grapefruit flavour, which interfered with some of her medication, and she had quite vivid dreams on that. She finally settled on the pineapple and orange flavour. That seems to be a firm favourite under patients. Symptoms reduced by week 2 of a severity of between 0 and 2. So we did a further 8 weeks of gluten contamination elimination diet, and she kept food and symptom diaries all along. I use the food and symptom diaries also just to check that patients are keeping strictly to this gluten-free diet, and also just to see whether I can pick out any other possible triggers for her symptoms. So by week 10, all of her symptoms resolved except for constipation, which was to be expected on the kind of diet we've put her on, because we adapted the Fasano diet a little bit, so we expected that was going to happen, just because we were suspicious that she may have other intolerances. But we were able to manage that with the Malaxol quite well. And in the last 5 months, she's only had 1 panic attack, which was a great improvement from, she used to have them at least once a week. So we were in touch with each other weekly, and we've identified other triggers for her symptoms. Dairy was one. Both lactose and cow's milk protein were triggers for her. Artificial sweetness, salicylates, caffeine, and sulfites were triggers for her. And her, like Cameron said, her weight improved. She's feeling great. She's still in touch with me now. We're still reintroducing things. But she just feels like she's got her life back. She can't believe how well she's feeling. Then our next one was a 49-year-old female who we saw in August. And she was a type 1 patient on insulin pump. She was non-responsive celiac, and her TTG was consistently high. It did improve from 65 to 9, and her EMA was positive. Her LFTs were really abnormal, and they did query whether she had atypical autoimmune hepatitis, and she was awaiting a liver biopsy. So again, we did a 2-week exclusive elemental diet for her, and we had to reduce her basal insulin by 20%. And at the start, it was a bit touch and go there as well to kind of figure out how much insulin she needed to give for each elemental drink she had. We didn't have any suspicions for other food sensitivities because she didn't really have any other symptoms. And so we were able to give her 6 weeks Fasano gluten contamination elimination diet, which is basically foods in their natural state, no dairy for the first 4 weeks, and also no gluten-free grains or pseudo grains. So we take out corn, we take out buckwheat, we take out quinoa, and so on. So it's really just white rice, brown rice, potatoes, kumara, is kind of the grains that they have, and just whole foods. So after 8 weeks, her LFTs nearly normalized. So ALT was 48, down from 104, AST 47, down from 110. You can see all of that came down. Her liver biopsy was cancelled. Her TTG became negative. HbA1c was 49, down from 58. All her cholesterol levels normalized, and she lost 5 kgs of weight. She was so happy with how much better she was. She's invited us to her 50th birthday party. So refractory celiac disease, as we said, that's a rare complication, and it affects only 1 to 5% of celiac patients. It's extremely rare in people under 30, but it can happen, but it's mostly diagnosed over the age of 50. So type 1 and type 2 differ in the way of being diagnosed, treated, and the prognosis or risk of complications. So type 2 is the one that we really worry about because it's got the poorest prognosis and the higher risk for enteropathy-associated T-cell lymphoma and ulcerative jejunitis. So type 2 patients are typically very unwell. So when they come to clinic, they are really ill. And their symptoms are like severe malabsorption, weight loss, persistent nutritional deficiencies, diarrhea, gastrointestinal bleeding sometimes. They could be having night sweats or bowel obstruction. They often require urgent attention of the gastroenterologist and maybe hemato-oncologist. And the input of a dietitian, the dietitian's role here would probably be around total parenteral nutrition or enteral feeding. You can also do nutrition therapy in refractory celiac disease. You can use elemental diet as a standalone or a combination therapy with drug therapies like steroids and chemo. But it is really vital for the dietitian to give regular follow-up and be compassionate in counseling these patients, educating them, for them to stay motivated to adhere to these strict diets. So the conclusion is really that as dietitians, we really need to be tirelessly thorough and creative on how to help our patients to overcome these barriers of adherence, coming up with ideas of, how to make affordable, cheap meals with gluten-free foods that are naturally gluten-free, what can I cook without cooking, or recipes that have only 4 ingredients, things like that, to overcome barriers of cost, for instance. We need to counsel for compliance without causing hypervigilance and impacting their quality of life. And I just feel like more needs to be done in terms of follow-up for our celiac patients, because throughout all the different stages of their life, they may run into barriers, and they may need support on how to overcome those different barriers to keep to a strict gluten-free diet. And I think more needs to be done in terms of training our dietitians on how to support our patients. Thank you. Thank you.
Thank you so much. We've had a few questions come through. First one was about finding out gluten-free, whether there's gluten-containing ingredients in cosmetics, for example, lipsticks and things.
Mm-hmm. So some of the fillers used in cosmetics contain gluten and can cause some contamination. And we actually had one of the girls that came through to our non-responsive celiac clinic. We've gone through all of that with her. We did the gluten contamination elimination diet, all of that. She did improve, but we still had problems with histological changes, but she was wearing a lot of makeup. So we then had to go and look at the makeup she was using, and some of the fillers used contained wheat, so we had to change it to a gluten-free cosmetic, and she has since improved. Yeah.
How interesting.
Yeah.
We've also got a question about whether you can use lactose-free products in that phase 1 of the gluten elimination diet.
So no, in our clinic we don't, just because we're trying to assess whether it's cow's milk protein or lactose. That's the problem. Yeah. So we kind of stay away from dairy altogether. Yeah.
Question about whether you recommend a food and symptoms diary for celiacs?
Absolutely. Well, I mean, if they have problems, yes, absolutely, I would definitely do that.
And final question is about use of elemental 0 to 8 versus Ensure as part of the Fasano diet.
Also because Ensure contains obviously dairy or cow's milk protein, so that is also the reason why we will not use Ensure Plus or Fortisip in our patients. I mean, we also know in our inflammatory bowel disease patients, I know that some people would use Fortisip or Ensure Plus for treatments of that, but we know that they contain some foods that might of some nutrients that may be immunogenic, and so therefore in our clinic, we prefer to use elemental oat weight because it's got fewer immunogenic nutrients in them.
Thank you.
Okay. Thank you.
That's it. I'm cutting back on my makeup.